you for the introduction. So I'll be talking a bit more about big data, but in particular how big data is going to change the way we do clinical research and patient care. And I'll also give 3 examples of big data studies that I'm doing as part of my PhD at Oxford. So our healthcare system has been rapidly changing over the last decade, in particular in the way that patient records are collected and then stored. We've gone from writing patient notes in bulky, moth-eaten charts to wheeling around laptops around the wards and typing our notes. And this has greatly increased the efficiency of our care, but it also has major implications for the way we do research. Traditionally, the way we would do clinical research would be we'd recruit a patient to a study, we might allocate them a treatment, and then we'd have to follow them up for several years to see if that treatment did anything. And we'd call them and ask them to come to our clinics, which is very resource intensive and costs lots of money. Now that we have a lot of important outcome data, such as heart attack, stroke and deaths, all recorded electronically in our healthcare systems, we can track this data using electronic data linkage methods. So instead of conducting small studies with expansive information on small numbers of patients, we can focus on collecting just essential information, but on very large numbers of patients, which is a big data approach. Just to show you the power of big data, we know that blood pressure increases your risk of heart attack and stroke, but about a decade ago, many GPs didn't prescribe blood pressure lowering medications to elderly patients because of some conflicting data. This study specifically looked at this. When they looked at 5,000 adults, all you can really see is that with higher blood pressure, there's increased risk of death from cardiovascular disease. And if you look across the age groups, that picture becomes very muddled. When you increase that number to 50,000, you start to see some trends across the age group. But it's not until when you have 500,000 adults that you can see clear observations across every age group that high blood pressure increases your risk of cardiovascular death. And we can conclude that in elderly patients, high blood pressure is equally as bad. With very large scale, we get fine precision and clarity where before there was none. I'll give you another example of the TASTE trial. This is a randomised trial of over 7,000 patients who had a heart attack and were then randomised to either normal management or to thrombus aspiration. And that involves sucking the blood clot out of the heart using fancy methods. Unfortunately, the trial showed no additional benefit from thrombus aspiration, but remarkably, they showed that you can conduct a large randomised trial without any contact follow-up. So after these patients were randomised and had their intervention, they weren't seen again. All their further events were just tracked using electronic healthcare records. This means a substantial reduction in the cost of randomised trials, which cost upwards of $10 million, but also means you can focus on recruiting much larger numbers of patients, which is what we need. So now to focus on big data for stroke prevention. Stroke's the second leading cause of mortality and the third leading cause of morbidity worldwide. About 1/5 of strokes are caused by something called carotid artery stenosis. And this is a narrowing of the large carotid artery in the neck, which carries blood from your heart to your brain. There's considerable uncertainty around whether carotid surgery should be offered routinely to patients with carotid artery stenosis. And this uncertainty largely stems from a lack of population data on the exact prevalence, risk factors, and stroke rates in people who have carotid artery stenosis. I'm conducting 3 studies as part of my DPhil at Oxford to specifically investigate each of these factors of carotid artery disease. And each of these 3 studies will use big data approaches. The first study is an analysis of the Lifeline Registry. This includes over 3 million self-referred, privately funded individuals from the US and UK who volunteered themselves for cardiovascular screening. They've all provided very detailed medical information, had routine blood tests, but importantly, what they've signed up for is cardiovascular screening. So they've all had ultrasound scans of their neck to see whether they have problems with their carotid arteries. We estimate that about 50,000 of these patients may have carotid artery stenosis. So using this very large data set, we can get precise estimates for exactly how many people in the population have this problem and what the risk factors for this disease are. Unfortunately, we don't have information on how many of these patients had strokes, and we don't have consent to look at that. So that's why I'm doing a second study specifically to look at stroke rates in patients with carotid stenosis. So this is the asymptomatic carotid stenosis cohort study, which is the study I'm starting from scratch. I'm looking to recruit several thousand or over 10,000 patients with carotid artery stenosis from NHS hospitals in the UK. And the purpose of this study is to find out the exact rate of stroke in people with this problem. All individuals will simply be asked to provide medical background, and a subset of individuals will be asked to give a blood sample for experimental analyses and have an MRI scan of their carotid arteries. And these additional tests are to see if we can find a high-risk subgroup of patients who have a much higher risk of stroke and clearly benefit from surgery. Using the big data approach, there won't be any further contact follow-up after the baseline visit. All stroke events will be traced through electronic record linkage, which minimises that burden of phone calls and also minimises the cost of the study. Finally, I'm conducting an individual patient data meta-analysis of clinical trials that have compared carotid surgery to medical therapy alone in patients with asymptomatic carotid stenosis. Individual patient data meta-analysis provides some of the highest level of evidence to guide clinical management. This meta-analysis will combine data from 3 large trials with a combined sample of over 5,000 individuals, and it should give very precise estimates of the perioperative hazards and the long-term benefits of carotid surgery. Using pre-specified subgroup analyses, it will also answer 3 important questions that we don't currently know the answer to. Is carotid surgery effective in patients already on best medical therapy? Is carotid surgery more beneficial in people with severe disease? And is there a high-risk subgroup that clearly benefit from surgery? So in conclusion, the electronic healthcare transition is changing the way we do clinical research, and there's a big shift to these big data methods, which provides population-scale evidence and is more likely to provide reliable results. And it's hoped that these methods can improve the prevention and management of cardiovascular disease and stroke. So I'll just conclude by answering this question: how can this technology benefit Australia? I think in the short term, it's hoped that we can adopt these electronic record linkage methods in Australia so we can answer important clinical questions in our own population. The technology is available, but we don't yet have the systems in place to conduct electronic record linkage from a national level to look at things like heart attack and stroke. And we also need to make sure that our ethics and our data protection laws and everything like that is up to date before we start doing that sort of research. In the long term, it's hoped that this research will clarify the best management of carotid stenosis. At the moment, we just don't know what to do, so a lot of patients are not receiving best management. If we can apply best management to everyone, then we should see the number of strokes caused by carotid stenosis decline. And that means reductions in disability, improvements in quality of life, and there's also major cost savings to be made. Thank you.